So you can start your sessions now.
Thank you. Good afternoon, doctors. Welcome to this experience sharing program on managing PPH, case studies from labor room. We have got honorable speaker, Dr. P. Srilekha with us. Welcome, madam. This program, doctors, is brought to you by Hetero Healthcare, an innovative pharmaceutical company. Hetero Healthcare, the journey began. We have got since 1993, and we have got 25 years of excellence with 36 state-of-art manufacturing facility. We have got 300 plus products in our portfolio and presence in 126 plus countries. Hetero Healthcare has 21,000 employees globally and is amongst the largest closely held pharmaceutical company in India. Hetero Healthcare is among the largest manufacturers of ARV, APIs, and FDAs in the world, and is Asia's largest API manufacturing facility at Visakhapatnam, Andhra Pradesh. Hetero Healthcare, the 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties, pioneering in quality and innovation, and has the distinction of bringing 4 biosimilar products to market within 5 years of initiation. Today's program, experience sharing program on managing PPH, Honorable Speaker Dr. P. Srilekha with us. Dr. P. Srilekha is MBBS, DGO, DNB, FMAS, FII, and Delhi. Academic qualification, Madam is consultant infertility specialist, obstetrician and gynecologist in Sai Anitha Multi-Specialty Hospital, Budupalli, Hyderabad. Srilekha's Women and Neuro Specialty Clinic, Habsiguda. Madam is expert in handling critical obstetric patients and having practical experience of in-house and outdoor care of obstetric and gynecology patients. Madam has presented paper and posters in TCOG, Telangana Conference of Obstetric and Gynecology, Warangal, and in a paper on clinical study of Hematology Conference of Pregnancy. Madam is member of FOXY. Welcome, madam, and over to you.
Thank you, sir. Thank you. So I thank Hetero Company for giving this opportunity. So today's topic is regarding postpartum hemorrhage, the use of Carbetocin. The introduction for postpartum hemorrhage, according to 2025 data from World Health Agencies, globally, postpartum hemorrhage affects millions of women annually and is one of the leading cause of maternal mortality, causing 45,000 deaths per year, 20% of all maternal deaths. So most PPH-related deaths occur in resource-limited settings. It's an unfortunate but yet common. And maternal mortality, leading cause of maternal mortality, according for about 35% of all maternal deaths. Maternal mortality rate is in developing countries was 40 per 1 lakh live births compared to 16 in developed countries. Globally, PPH incidence is 14 million women suffering from PPH. Incidence of PPH is reported as 2 to 4% after vaginal delivery and 6% after cesarean section. PPH incidence in India is 38% of maternal deaths are due to PPH, and 25.7% of global deaths take place in India, and 2/3 of these attribute to PPH. India has an unexpectedly high maternal death rate of 540 per 1 lakh live births. Next. So coming to etiology of postpartum hemorrhage, there are 4 T's. First T is tone, uterine atony. It's because of the uterine atony. Inability of the uterus to contract, which may lead to continuous bleeding. Next T is thrombin, coagulopathies, failure in clotting. Here, it refers to a deficiency in the blood's clotting ability due to a bleeding disorder or coagulation issues, mainly in DIC, like HELP syndrome, abruption, amniotic fluid embolism, von Willebrand's disease, platelet function disorders. And third is trauma, uterine trauma, injury to birth canal, rupture of uterus, and uterine inversion, laceration, cervical lacerations. And fourth is tissue, retention of placenta and clots and abnormal placenta. Next. So this slide shows the clinical findings in PPH. We see abdominal tenderness, circulatory collapse, increasing abdominal girth due to accumulation of blood clots in the uterus, loss of uterine contraction, maternal tachycardia, vaginal bleeding. We have 4 degrees of shock, that is compensation, mild, moderate, severe. according to the blood loss, blood pressure, and symptoms and signs. In compensation degree of shock, we have a blood loss of 500 to 1000 ml with no changes in the blood pressure. The patient will be experiencing palpitations, dizziness, tachycardia. In mild degree of shock, there's a blood loss of 1000 to 1500 ml with blood pressure slight fall of in the blood pressure, and patient will be experiencing weakness, sweating, tachycardia. In moderate degree of shock, there will be a blood loss of 1500 to 2000 ml with marked fall in the blood pressure, and patient will be experiencing restlessness, pallor, oliguria. In severe degree of shock, there will be 2000 to 3000 ml of blood loss and profound fall in the blood pressure, where the patient will be experiencing collapse, air hunger, and aneurysm. Next slide. How can we diagnose postpartum hemorrhage? Initial evaluation by 3 methods, by 3 stages. Initial evaluation, examination at the time of hemorrhage, and laboratory assessment. Initial evaluation, rapid assessment of the patient's status, presence of tachycardia and hypertension, assessment of vital signs, and blood loss. In examination, we assess entire genital tract for lacerations, hematomas, or signs of uterine rupture. Manual examination for retained placental tissue, assessment with bedside ultrasound to check if the uterus is non-contracted. Evaluation of uterus to check for uterine inversion. In laboratory assessment, complete blood count to check hemoglobin, hematocrit, and platelets, coagulation studies, and assessment of fibrinogen. Next slide. So this is the approach for postpartum hemorrhage, the 4 T's, how to find them, what all to be investigated, and management. In poor uterine tone, so as we said, there will be uterus is relaxed, boggy, and soft. We can feel the fundus of the uterus above umbilicus. The investigations order at that time is full blood picture, coagulation profile, urea, serum urea, and electrolytes. Management is by uterotonics and uterine balloon tamponade and surgical devascularization. Next T is tear or trauma. Here we can see the uterus is contracted, but yet bleeding is present. The causes are uterine rupture, extension of uterine angles, and tears during cesarean section. Investigations are by exploration, by exteriorizing the uterus during cesarean section, and ultrasound. Management is repair of identified genital tract trauma and pelvic arterial embolization. Retained tissue, we can find them identified by bimanual examination and examination under anesthesia. Management is manual removal of placenta and products of conception under anesthesia, regional or general anesthesia. Coagulopathy, continuous bleeding and contracted uterus. Investigations are urea and electrolytes, full blood count, coagulation profile. Management is immediate replacement of blood and coagulation factors and platelets. Surgical only with trauma or atonic hemorrhage, unresponsive to medical management. Next slide. This is a slide showing the advantages of Carbetocin. So Carbetocin is a newer drug which is stable at room temperature, has shelf life of 24 months at 30 degrees centigrade and 75% humidity, avoids need for cold chain storage and logistics, and is provided in a vial, and it is very useful in resource poor countries. Next. The slide shows the uses of uterotonic agents. We have to give the uterotonic agents at the time of delivery on the anterior shoulder of the baby, and prophylactically for prevention of PPH, active management of 3rd stage of labor. Therapeutic uses are management of PPH. These are the molecules: oxytocin, carbetocin, ergometrin, symptometrin, misoprostol, available in the market. Next slide. Next slide. So this is a slide showing the mechanism of action of carbetocin. Carbetocin binds receptor binding triggers activation of phospholipase C and the generation of the second messengers IP3 and diacylglycerol, which induces the release of free calcium from intracellular stores, which causes binding of calcium to calmodulin, stimulates uterine smooth muscle contractions by activation of myosin light chain kinase. So single IV dose of carbetocin, 100 microgram administered after the delivery of baby is sufficient to maintain adequate uterine contraction, preventing uterine atony and excessive bleeding with efficacy comparable to hours of oxytocin infusion. Next slide. So this slide shows the differences between oxytocin and carbetocin. So oxytocin is a synthetic cyclic peptide form of the naturally occurring posterior pituitary hormone, binds to oxytocin receptors in the uterine myometrium, stimulating contractions of this uterine smooth muscle by increasing the sodium permeability of uterine myofibrils. Whereas carbetocin is a long-acting synthetic analog of oxytocin with agonist properties, binds to oxytocin receptors in the uterine smooth muscle, resulting in the rhythmic contraction, increased frequency of existing contraction. This is very important action of the carbetocin, and increased uterine tone. Coming to the pharmacokinetics, oxytocin, when given IV, almost immediate action with peak concentration after 30 minutes, whereas carbetocin is a sustained uterine contraction within 2 minutes, lasting for about 6 minutes and followed by rhythmic contractions for 60 minutes. Oxytocin, when given IM, slower onset of action, taking 3 to 7 minutes, but produces a longer lasting clinical effect up to 60 minutes. Half-life is 1 to 6 minutes. When carbetocin given IM, sustained uterine contractions lasting for about 11 minutes and rhythmic contractions for 120 minutes. Its half-life is 40 minutes. Storage and transport, oxytocin needs a cold chain maintenance of 2 to 8 degrees centigrade continuously, whereas carbetocin up to 30 degrees centigrade it can be sustained. Clinical indications of oxytocin are it can be given in induction of labor, augmentation of labor, prevention of PPH, and treatment of PPH, whereas carbetocin can be given in prevention and treatment of PPH. Next. So there are many trials done with carbetocin, showing that carbetocin is not inferior to oxytocin. One of them is WHO Champion trial, where there are 30,000 women across 10 countries were included. The primary outcome, the proportion of women with blood loss of at least 500 ml or the use of additional uterotonic agents, and the proportion of women with blood loss of at least 1,000 ml. Next. And this slide shows a minimum, very minimum advantage of carbetocin, but this very minimum advantage, like showing the 14.5% efficacy, 1.51% blood loss of more than 1,000 ml. This is very important in delivery cases, that 1 minute, half minute, 2 minutes extra also is very important when there is PPH and blood loss. Conclusion is carbetocin was non-inferior to oxytocin for the prevention of blood loss of at least 500 ml or the use of additional uterotonic agents. Next slide. According to Cochrane's review, there were 11 studies involving 2,635 women were included. So here they have concluded that for women who have undergone a cesarean section, carbetocin resulted in a statistically significant reduction in the need for therapeutic uterotonics compared to oxytocin. Also, carbetocin is associated with less blood loss compared to symptometrin in the prevention of PPH for women who have vaginal deliveries and is associated with significant fewer adverse effects. And the guideline recommendations are, and many countries they have stated that carbetocin is the drug for prevention of PPH, effective and preventive. Next slide. So I'll be sharing my experiences with carbetocin.
Yes, madam.
So, case one is 25-year-old primary gravida presented at 38 weeks in labor. Her vital signs, including blood pressure, pulse rate, respiratory, and temperature, are within normal limits. On abdominal examination, the uterus is larger than expected of gestational age with dense, shiny abdominal counter because she was having excess liquor. Fetal heart rate was 145 to 150 beats per minute, and fetal movements are present. And ultrasound evaluation reveals an amniotic fluid index of 20 centimeters, confirming polyhydramnios with otherwise normal fetal anatomy and adequate fetal growth. The fetus is in cephalic presentation and Doppler studies are normal. There are no signs of maternal distress or complications like hypertension, diabetes, or infection. So we have, as it is a primary gravida, and only one issue is like amniotic fluid index is more. We have waited for, and we have augmented the labor, and delivery of the baby was uneventful. And prophylactically, we have given carbetocin to avoid postpartum hemorrhage, as it is over-distended uterus. We have expected this PPH, and we have given 100 microgram carbetocin IV priorly after the delivery of the baby, and like minimum blood loss. What is to be expected was more, and the man like balloon tamponade, use of 2 or more uterotonics were not there. Simple carbetocin has saved. Yes. The second case is like she's a multigravida, 35-year-old, second pregnancy, twin gestation, and 37 weeks completed. So we have planned for elective repeat section. And in her case also, like no comorbidities. The first fetus was in cephalic presentation, and second was in breech. To avoid the labor risk like scar rupture and fetal distress, we have planned for a repeat LSCS. In this case also, after the delivery of the second twin, we have given carbetocin prophylactically. In this case also, it's a case of over-distended uterus, and we can expect postpartum hemorrhage. So carbetocin has, after giving carbetocin, there was very minimal blood loss, and the postpartum period was only.
Madam, before I come to questions, very interesting, So how long you have been using carbetocin, madam?
From my learning phase, where my teachers used, from my personal experience, it has been 2 years.
2 years. And you have generally used it in as IM or IV or depending on the case?
So mostly IV.
Yeah. Before I go to panel questions, there's one question I will ask you. What is the advantage of using carbetocin in the first line?
Carbetocin, more of belief, sir. It 100% reduces the loss. That belief should be there actually.
Yes, that is correct. But in
And
your experience, it has stopped. I mean, the
yes,
future comes. Yes.
yes.
Because as you rightly said, PPH is one condition which is good to discuss and debate and see the slides, but it's worse to manage. One should never get a case. I
It's
mean,
a big nightmares.
yes. And what are the general patient profile where doctors can anticipate a PPH?
Twin gestation, gestational diabetes, polyhydramnios,
Yeah, you got both these
hypertensive
cases.
cases,
Yes.
and anemic patients where we
Our
have said
country
like
anemia, yes.
500 ml of the blood loss in vaginal delivery. There can be
Yes.
even like deterioration in the hemodynamic status even with 200 or 300 ml.
Yeah. Anemia is very common in our country. But
Anemia is
madam,
very
patients with fibroids or maybe PCOS patients
common.
can get a PPH. Are they prone for PPH?
Fibroid patients, they are prone.
Your
Uh,
PCOS, not per se.
PCOS and if they get GDM in their
Of
antenatal
course.
period, then they are prone.
They- And the one golden rule is that expect the unexpected. Any patient can get.
Any patient can get,
I mean,
even if it is a
I've seen,
briny,
I've seen patient going normally and delivery happens and everyone is happy and suddenly the PPH starts.
suddenly they become
Yeah, yeah, yeah.
yes, sir.
And the whole
Even
hospital is
in the
there.
yes, sir. Even after 24 hours, 48 hours,
Yeah, yeah,
some
yeah, yeah.
patients come after even after 10 days.
Correct, correct. Acha, even after 10 days, secondary PPH. Like,
Secondary BPS.
can you use any experience of using it in retained placenta?
Within placenta, when I was studying that time, we have seen, sir, in retained placenta, like it's safe from like going into removal under anesthesia.
Okay, yeah.
So after giving,
Yeah, yeah,
easily
yeah.
we could have removed the placenta.
Placenta. And in case of RH negative mothers, have you tried carbetocin?
Yes, sir.
Yes.
Like we can give.
Now, most of our doctors use oxytocin for labor induction. Almost everybody, that's our textbook brand. So, if they use oxytocin for labor induction, can they use carbetocin for PPH? I'm asking because both will act on the same receptors.
Yes, yes, yes. We can give, sir.
Okay.
We can.
Oxytocin action is short-lived.
Short-lived and
Yes.
Carbetocin can be.
You generally prefer IV routes, but is there a place for IM?
There is a place, but that's what the belief. I give off IV better. Why to wait that many minutes also for the action?
And every minute will matter in
Every
PPH.
minute matters. Give off IV.
Yeah, taking this clue for the every minute matters. Would a pre-filled syringe be of advantage to you for carbetocin?
Sorry.
Now we have got ampule, etc., vial, etc. You have to cut and take the injection and give syringe in the give. Suppose we
Uh-huh.
give a pre-filled syringe, will it
Yeah.
be an
Okay.
advantage?
Yes, sir. Once if we are expecting like in cesarean section, we priorly inform. Actually, my anesthetic like
Anesthetist,
after
yeah,
delivery of the baby, he'll be watching me. If necessary, he will give off.
straight, yeah. And
If
anesthetist can
normal
read,
delivery, yes, normal delivery, I'll be just keep ready, give it off.
yeah,
That's a
correct.
single.
And
So
anesthetists can read a gynecologist's face, and they can, I mean, with the experience, they will know when to start.
when to
That's the
start.
teamwork, yeah.
Yes, yes, sir. And pre-filled syringe, if we are not ready also, in that cases, it is very easy to.
Yeah, yeah. And in places where, there may not be help. I'm especially talking about the interiors.
Yes,
Yeah,
yes.
yes. And any adverse effect that you have seen with carbetocin?
No, sir.
No. Thank God. PPH itself is
No,
a
yes.
yeah.
Yes, oxytocin has like decreased
Yeah, yeah.
urine
ADH is an
output,
effect. Yes, correct.
and misoprostol
Yeah,
means like loose motions, vomitings,
yeah.
raised body temperature. Those are all
Yeah.
not seen.
I mean, the worst part of it in the golden moments of a lady, if those adverse effects happen, it is a little disturbing. Huh?
Yes,
They may not
yes.
be severe, but then, yes.
Yes, sir.
If the patient is not responding adequately with carbetocin, then in your order of preference, which you use, if I ask which other, it is everything. But in order of preference,
Carbetocin, we can give another dose of carbetocin, but I never experienced.
no, acha, you had that. Thank God. I will not take this question further. What are the advantage of carbetocin over other uterotonics?
That's what the advantage is. No side effects.
No
The
side
room
effects.
stable,
Yeah, yeah, yeah.
temperature cold chain. Many of the
I think,
hospitals can't maintain that cold chain.
yeah.
The
And
efficacy will be lost.
absolutely. And even if the hospital is maintained, we do not know the transport chain how it is.
How it is, yeah.
Yes, that's and power outage happens everywhere, including Mumbai, including big cities, Hyderabad, everywhere it happens. So
Yes,
you
yes.
can't really be sure.
We go on giving, but it does not act.
It doesn't work.
Then
Yeah.
blood loss will be going on.
We have answered this question already. Should carbetocin be
It
kept as a reserve
will
drug?
be
Yes, it
first
should be a
line.
first line here. Now, the role of anesthetist. The anesthetist judges of obstetrics reaction and acts. But is the anesthetist who takes a call or obstetrician takes a call?
We have a prior talk, sir, like regarding the case.
Okay, yeah. So it will be
So
case to
we
case.
case to case, we'll discuss, and if it is necessary, we'll say like, don't wait for my
Yes.
call, just give it off.
Yeah.
Because no side effects are
Yeah. And anyway, hemodynamic parameters are generally seen by anesthetists.
there. Yes.
Generally, yeah. And with the teamwork, and anesthetists would know when to interfere. I
When
mean that rapport is there.
yes, sir.
And one of the anesthetists told me, if a guy give carbetocin, then I'm relaxed. I can go to the other room.
That's what.
In the
Yes.
sense that yeah, it will act a little longer. I mean, that happens in our country.
Yes. Even if the pediatrician has not arrived, he can just
Yeah,
give the
correct.
carbetocin and he can attend
Absolutely.
the
Next delivery. To conclude, take home message for the audience.
Carbetocin is the best drug uh, as far as I've used, and it is very important, like to avoid PPH.
Yeah,
Uh,
absolutely.
Carbetocin will be the first line of management than the tranexamic acid, oxytocin, anything. How many of our
Yes.
trials are there over that? We should give carbetocin as the first line drug.
Firstly. Right, madam. Thank you so much for your time. I
Yeah.
mean, evening time is an OPD time. Thank you so much for taking time and attending this. Thanks all the doctors who took time from their schedule and attended this. And thanks, Bhuvan. Thanks, Bivas. Thank you so much. I'm sure the audience has benefited out of your question answers, especially, guiding us. Thank you. Because practical experience is one which the doctors want more than the theory. That's what gives
Yes.
them confidence. Thank you.
Yes. Thank
You
you, sir.
can log off, madam. Thank you.
Yeah. Thank you.
Thank you, ma'am. Thank you so very much.
Thank you.
Once again.
Thanks, Vivas. Thanks, Bhuvan.
Thank you, sir.